Greg, I'm super interested in learning about your career path. Not very often you meet someone who has a degree in physical therapy, is a doctor in chiropractic, has a master's degree in biomechanics, and has done as much research as you have. So that is super interesting, and I'm so curious as to why you chose to dedicate so much of your life into academics and research, and what kind of questions were you trying to answer, and I don't know, just your why.
I'm just super inefficient. I could have done it way better. I just messed up. A lot of it, like I did my undergrad in kin, and I was going to go to Apparel, but I had massive doubts back then, like 20 years ago. So that's why I did my master's first. So I'd say the driving force would be like insecurity, or just thinking that no one knows anything, myself included. So that's why I did the master's, and then I went to Cairo, and then years after being in practice for 5 years, I went back to physio, and that's the reason for that. It's certainly less noble, but Cairo, as you guys know, has more of a dodgy, reputation.
Oh yeah.
In Canada and North America, and it's just an easier road to hoe as a physio. And so I had my own clinic, and I was working full time, and I just went, and we had 2 babies, or one baby on the way, one baby and another baby on the way. And I just went back to physio school because it was kind of easy. It was just down the street from me. So I got my physio degree more just to open doors, to be able to travel and work and all those things. I know that's horrible. I wish I could say it was like for something more noble and enlightened, but it was just easier.
What was it specifically that you were insecure about in terms of your knowledge?
So when I was like 21, 22, I was really into biomechanics and low back pain, and I thought chiro was the route, but I had doubts about the chiro profession and the chiro training at the time. So that's why I thought I should do a master's, and I was lucky to go to Waterloo. That was the big thing. So I just was reading a lot, and I was skeptical of the profession. I still am. So that didn't change.
Preaching to the choir.
You worked under
what's that?
Preaching to the choir, man.
Yeah.
Worked
normal.
under.
That's okay. You get used to that.
Yeah.
Sorry.
Yeah, go ahead.
You worked under Dr. Stu McGill?
Yeah, 20 years ago. Yeah.
Wow. How was that?
He was great. He was a great, he's like your PhD or master's supervisor. And what I thought his strength was he would take on lots of different people and let them run with their research ideas, but then really give them the advice and the guidance and the freedom to do a better job of it. He wasn't a micromanager, but he put in the environment to let you do what you want. And that's why when you look at his research career, it's varied in some ways, where he works with a lot of different people. So that's certainly what I learned there. He wasn't really seeing a lot of patients when I was there. So I didn't get a lot of clinical training. I didn't get really any clinical training there.
How would you say that your views have changed over the years since working with Dr. McGill? Because from what I read from your articles, or from what I gather from your articles and your videos and presentations, I feel like your views have changed from being overly focused on biomechanics, mechanics, and kind of like that simplistic model, and has evolved over time to a more encompassing one.
Yeah, it's, you know what, even 20 years ago, we knew, and I knew that pain was multidimensional. And actually my biomechanics degree acknowledged that, and they tried to have people consider the psychosocial factors. So I was actually introduced to those doubts and those ideas really early. But how I've changed would be, I'm, like I say, I'm a movement optimist, which means I recognize that there's a lot of ways for people to move well, not just one, and so I really have fundamentals, like viewpoint on how we adapt positively to stress and load. And that's why I don't get too caught up in technique for pain or injury. Performance is different. So that's certainly how I've changed, where I have a lot more options on how people can move and do well. That would be the biggest difference.
That view point resonated with me so much because even before you were diving into reading his stuff, you helped me with my patellar tendonitis. That was something that bothered me for years. I would just avoid things like walking lunges, remember? I felt like I was literally going to break my knee. And then you're like, you need to practice doing more walking lunges. And it was literally just reintroducing that movement that I thought was going to kill me over and over again, slowly, with some progression, and now I have no knee pain. So it's like that really resonated with me when I was reading some of your articles, because I've lived it and I've gone both routes, and the reintroduction was really valuable for me, I think.
Yeah, that's it fundamentally. Like the kinesiopath model or the traditional biomechanical model it's more avoidance than exposure. It's not that it's not exposure, it's more avoidance. And like, if you're going to expose, you have to do parameters. And I think I've sort of moved away from those rules and parameters and just focused on good loading, training, progression, and that stuff. I think those things are more important. And where the pain science comes in is, so someone else who might have had knee pain like you had, they might have been really worried and fearful. And so there's a little bit of cajoling and building optimism and addressing that fear and that concern, so that the mechanical aspect of the treatment can now occur. That's how the multidimensional nature fits in there.
Can we go through the difference between the kinesio model, movement optimism, and the biopsychosocial model, and where your views lie?
So the biopsychosocial would just be this overarching theme that says that pain is influenced by a number of factors, psychosocial variables, and then biological variables, which it's tough. Like biology is also psychosocial, like means your beliefs and contexts and psychological factors can influence your biology, can influence how sensitive your tissues are. So it's just recognizing that it's not bio, then psycho, then social. It's everything overlapping. It should be one word together. So that's the overarching. And then the difference between the kinesiopathological model could fit into the biopsychosocial. It would be part of it. But where movement optimism would be different from the kinesiopath is that we would acknowledge that biomechanics and biology and exercise and mechanical interventions are important. They're just important for another reason than what the kinesiopath model suggests. So the kinesiopath is that classic, like your joint is out of place, your SI joint, your knee caves in 3 degrees when you walk. So there's more load on the patella. That's why you have pain. The more optimistic view is, great, your knee caves in. Well, that's a load that you can adapt to. Don't worry about it. We just have to find the right amount of stress for you to let your knee cave in. Maybe we avoid it for a month, but slowly we start, applying that load again. It's sort of like your knee, what people would say, don't let your knees go over your toes, right? That's a kinesiopathological model idea. And now we've sort of thrown that out and just said, no, that's just load. You adapt to it. Mm-hmm. So I think you can do that with valgus or pronation or spine flexion or shoulder dyskinesis. Does that make sense?
Yeah, absolutely.
It's just a slight massaging of the KPM, not to worry about it so much, but we're still acknowledging that biomechanics and biology is important. Just there's other factors that are important.
So what are the conditions in which biomechanics, in which it's important to address biomechanics?
So, well, you got like performance. I think that's cool. Like where we can probably agree more, like how you move and how you use your muscles. Performance. That's probably the biggest area. And then now we have to have the debate. Well, what's the right way to move for your performance goals? So I think high load activities, how you move is more important. When it comes to endurance, I think it's less important. I think you can have a lot more variety. I think in higher loads, there's probably less variety where you see people getting into the same shapes, right? Like I started doing gymnastics just a few years ago. and I would just run before. So now I want to go backwards, and like your backflip there, Steffi, if you want to do a back handspring, you have to have, or like the snatch, you have to have good, thoracic extension and shoulder flexion. Well, I don't have jack shit. So my back handspring sucks. And if I had more, those biomechanics would be something as simple as that. Yeah.
Mm-hmm. Do you find it difficult to change people's beliefs about certain movements and certain postures? And if you do, how do you address it? Because I was having a conversation with Hayden yesterday about how, we understand the concept that there's no movement that's bad for you, that potentially you can bend with your spine in a flex position, and that doesn't necessarily mean that something bad's going to happen, and we accept it. But it's so, like Hayden was saying, there's no way that I'm going to
I'm so tied to those previous beliefs. Like, even though when I was reading your articles, I was like, yeah, I understand all of this all makes sense, but I still don't want to see somebody deadlifting with a question mark shaped back,
Yeah, it's so deeply ingrained.
And for no real reason, I think, other than it, we've just been told that that's an ugly movement, maybe, and it's stuck in my head so much, and so much in fitness culture in general, that we see that, and our immediate reaction is, oh, that's bad.
Mm-hmm.
Yeah, I'm smiling because I do the same thing. So that's how I always taught a deadlift or a squat. And so I won't go out and teach someone to lift something heavy with a fully rounded spine. Because again, I think it's performance. I think there's trying to cue a neutral spine, which we know isn't going to happen. You're still going to flex at least 60 to 80 degrees. But I think what you'll end up avoiding is 60 to 80% of your max. The total lumbar spine flexion is probably 50 degrees. So you're probably flexing 40, although it looks like you're a neutral. The cue to try to be a neutral probably helps you avoid 100%.
Wow.
And even though you're flexing 60 to 80. So I think there's a performance rationale where if you cue neutral, your hips are probably going to get more into it. You're going to get like more of a hip extensor moment. You'll get more stress on that tissue. So there's still good reasons to do what you guys traditionally do, would be the idea. But if you saw someone lifting and they were excelling and getting stronger, and it looked like their lumbar spine was a little more flexed than someone else beside them, then maybe you wouldn't worry about it so much.
So
does that make sense?
Yeah, absolutely. Makes sense. Since we're on the topic of back pain, Ian and I are super interested in that. We're actually in the process of writing a book about back pain. Well,
that should be easy.
Yeah.
Well, there's a lot of your stuff in it, so it's pretty easy.
When a patient comes in with back pain, where do you start? And I always, the first thing that drew me to your stuff was, I think I found a presentation where you were talking about stability and how it's really not that important. And, we have to change the narrative about the correlation between instability and pain. I thought that was so interesting. And that's kind of like what threw me into the rabbit hole of researching more about back pain and what it means. So yeah, I would love to hear your thoughts and kind of like your process when someone walks in with back pain, and kind of like how do you incorporate elements of the biopsychosocial model, and how do you kind of explain to them what pain is, what it means for them, and what the process of rehab looks like?
Yeah. So starting with the end there, the process of rehab, that's a question we should all ask. Like, I don't think people do this enough when they teach a course or practice, where you kind of want to say, like, what has to happen for this person to get better? Like, what mediates recovery? What's the end goal? If this person is out of pain, what do they look like? How are they different, 6 months from now or 2 weeks from now than they are now? Like, those are questions we don't ask enough. Like, what really allows someone to be pain-free or to be doing really well with the pain that they have? So I think like if I had to work like with a goal in mind, it's usually the important things that I think mediate recovery are like getting people back to doing the things that they love. That's like the hugest thing. What are you missing? What do you want to be doing? What's getting in the way of you doing the stuff that you want to be doing? And it's, the true,
Greg, can you repeat?
You guys there?
Yeah, can you repeat that from what's getting in the way of you doing the things that you want to do?
Yeah, so it's the idea, like we want to, you find the things that they love and that they want to be doing, and then you kind of have to figure out, okay, what's stopping them from doing those things again, right? And so if it's deadlifting, we have to get them deadlifting again, but they might be worried about deadlifting, or they might be caught up on a certain position, or maybe they're over bracing and they don't need to. So you change their deadlift style. Or when they have started to deadlift again, they've just done way too much, way too soon, because they remembered when they deadlifted 3 years ago, they could deadlift 400 pounds. And now you have to say, no, it's okay to start with 50, because 50 turns to 100 and 100 turns to 200. So like you kind of want to find what are the things that are driving their sensitivity, or that are stopping them from doing the stuff that they love. And I think that's where the psychosocial interacts with the biomechanics. So your mechanical treatment is, let's have you slowly lifting again. Maybe we do it. That's potentially something that you do. So that would be like a mechanical tweak. But maybe they just had a really poor loading progression. And then you want to say, okay, what are all the other drivers of sensitivity? Maybe they're not sleeping well. Maybe they're not exercising in general. Maybe they have, some fear and worry that they need to address. And then maybe they have other things that we as physios can't help with, like some driving anxiety or depression where someone else needs to help us out. So you're just sort of saying, like, how can you be healthier? That's like a question I always ask my patients. So usually we end the session with that. Like, where do you think you can be healthier? And what do you think I can help you with? That sort of idea.
Yeah. Well,
I feel like every single power lifter needs to go see you, because you just described the exact dilemma that most of us get into, where it's just poor loading progression. You get injured. You remember how strong you were at your strongest,
and then you do that thing.
Yeah, you're constantly measuring yourself to that one number, and then you just dive in way too fast, get hurt, and do repeat this cycle for your whole career.
And our biggest issue is that kilos, pounds, weight doesn't mean anything anymore. We don't understand how heavy 50 pounds are.
Yeah,
it's like, okay, week by week, cool. I'll just add 100 pounds week by week. Because weight is not weight.
Well, you're so out of touch now. It's like being a billionaire. Like, what's a coffee cost? $1,000?
What's a gallon of milk? Who even drinks a gallon? But what I love about that approach is it's so much simpler than people make it out to be sometimes. But and it's grounded in experience and in the way you relate to people and in what's relevant to them. But I think, right, sometimes, clinicians and patients alike feel like it's soft and hard to grab tangibly, and they're looking for the 17 dysfunctions in someone that they know are causing their pain, that they can assign credit to and that they can address, and then they have, unwavering faith that the correction of those dysfunctions will lead to the resolution of pain, and that they fixed everything and that everything will be great.
Yeah.
And it seems like both patients and providers are participating in that. When the patient comes to you and says, I know this caused my pain, right? They're assigning credit to a very specific event. How do you begin to untangle that with them to get to this place?
So sometimes let's say you don't think they're right. That's okay.
Yeah.
But if you, so they might have a false belief. You don't always have to address every false belief.
Right.
So you got to decide that belief is unhelpful. Right. So you could still incorporate a good progressive loading program that would help also address that whatever perceived dysfunction they have. So you don't have to challenge everyone and tell them they're wrong all the time.
That's fine, though.
But if you think it's getting in the way, that's where you have to, gently look for things in their story and their exam that would gently challenge that belief a little bit. And you want to give them a better explanation for their pain than anyone has ever given them before. That's sort of the idea. I know you've been told this. That makes sense. Those treatments can help you turning on your glutes when you're walking, but you've tried that. From what you've told me, it sounds like there's these other factors going on with your pain. Do you think that we could work on that for a bit? It sucks, but we almost have to be salesmen, which I don't like being, but that's the idea. You're selling your patient's story back to them. Like you really understand understand what's going on. That's the idea. So you give them a better explanation. That's how we address that. But I would say when people think that there's like a therapist thinks there's those 17 things they have to correct, if you watch what they do with the sound off, often it's just a good loading program, but they have this corrective mentality, and you look at it and you're like, oh, you're just slowly progressively loading them to the things they want to do, but your rationale is movement correction, when really what it is, it's loading and adapting and calming shit down and building shit back up. But we just can't say it that simply. We need to say the fucking TFL is turning on wrong or something, or whatever muscle's wrong.
Yeah.
today.
You think we can get to a point where that stops being the norm and it's kind of replaced by this model that you speak about?
No. People are digging in, man.
Oh, we're doomed.
You'll have a few people who like will embrace this.
I don't know. I feel like
we're gonna get a reaction. I think it's gonna double down. There's just a massive JOSPT had a whole journal dedicated to motor control bullshit.
We read that whole thing. Yeah.
But I feel like at least now people are having this conversation more often. You know, before that, I think that the whole biomechanical model was it. That was the law. Like that was the truth, and
whenever
that's just what everyone accepted.
And whenever you challenged it, people would eat you alive.
But now it's become like an actual debate.
Yeah. I don't feel so alone anymore.
Yeah.
Yeah, no, you shouldn't. When I was in physical therapy school a few years ago and we started learning about orthopedic tests, I came home crying one day to Hayden, and I'm like, either I'm the stupidest person on earth because I can't feel anything. I can't feel the joints moving. I don't understand how these tests are magically going to tell you exactly what structure is damaged, or everyone else is wrong.
Yeah, you're way smarter than the rest of them. That's the reality.
Yeah, but it was so frustrating. And whenever I would speak about it on my social media or with my classmates, I would get a lot of hate, and people wouldn't like it. People didn't like it. I find it interesting that when you speak of your approach, you didn't mention at all core stabilizing exercises. And I feel like that's where most people begin, or that's what people think when they think about a back rehab program.
Yeah, I just look at them as like progressive loading exercises, right? And I do them when I want to when someone wants to get built up to do the things that they love. That's when you do those exercises. Because I have a lot of patients where they've done so many core exercises, they have this idea that their back needs to be fixed. And I'm like, do you want to stop doing those? Do you like doing those? No? Okay. Well, there's other things that we can do then, right? You can use your goal activity as a stressor for your back to calm things down. You can start running again. You can walk, you can hike, you can rock climb. So I only do like basic core exercise if they have some, like I'm a good example. So back to gymnastics, like I wanted to do backflips again, and I kept injuring my back and tearing my abs. So my goal activity, my meaningful activity, was way beyond what I was currently capable of. Right. So I had to go back to do sit-ups and leg raises and whatever, all the boring old core exercises to build me up to do the meaningful activity. That's when I think they're relevant. But for the average person with low back pain, they don't have some deficit that needs correcting. Mm-hmm. They just need to get moving again, usually. Mm-hmm. So core exercises are one option. I just don't think that I think that they're rarely ever necessary. Does that seem fair?
Yeah, absolutely. What even is the meaning of stability?
So typically, like in the biomechanical world, it's mechanical stability, where if you perturb a system, like push something, it'll wobble. And then if it comes back to its resting position, that means it's stable. So just because something moves a lot, like a willow tree in the wind, it doesn't mean it's unstable. An oak tree is just more robust, meaning it doesn't bend as much. So when something's stiffer and you can have something less stiff, it doesn't mean it's more stable. It's just more robust. So stability just means you perturb something, it'll come back to its resting state. So surprisingly, there's very little research that says that people with low back pain are unstable. It's pretty amazing. It really hasn't been tested. I'm laughing because it's hilarious because we throw that term around. I think stability is like what the research has said is has shown us that stability is important and that it's complicated how we achieve it, but it's never something you have to worry about. That's what I think. It's like growing your hair, unless you're going bald, then you have to worry about it. But anyways, like growing your fingernails. There's probably a massive science behind how your fingernails grow. I bet it's really complicated, but I never have to think, I got to focus on my fingernail growth today.
Yeah.
That's what I think. I just made that analogy. I don't know if I'm ever going to use that analogy. This might be a one-time usage.
I like that, actually.
You just don't have to think about it. And that's kind of what I think about stability for the most part. High loads, or like some gymnastics, maybe lifting or rock climbing, maybe you need to add a little bit of co-contraction because you want to avoid a movement pattern. But I still don't think most people with low back pain are unstable.
Yeah, that's something I think you've mentioned before, is the amount of redundancy that you can see in that kind of system. People think that they're always on the verge of some sort of catastrophe or compromise, and that we actually have pretty enormous buffers that we can measure against the things that we do on a normal day-to-day basis, right? Maybe not putting 1,200 pounds on your back, having never done it before, but pretty much anything you can reasonably encounter. So I definitely like that idea.
Yeah, it was funny that you mentioned earlier that sometimes people are getting the right end result, but the way that they're getting there is not necessarily correct. And I think you see that a lot in PT. Because I was telling you, again, yesterday, we were talking about this, where I went to a bunch of different physios in Canada when I was playing hockey. I was having some lower back pain, and, nobody really was able to help. Finally, I went to one guy, and he told me that my glutes were firing at the wrong time and that I needed to do a bunch of back extension to correct it. And at the time, not having the right context, I thought that this guy was a guru. This was like, oh, my glutes weren't firing.
I found my guru.
Now I do these exercises and it's corrected. And so he must have been right.
Uh-huh.
But his process wasn't right. You know what I mean? It wasn't a glute firing issue. Like you said, I avoided the pains the things that were causing pain.
Yeah.
I slowly was reintroducing movement and progressively overloading it. So it's literally following the exact model that you've spoken about, but I thought I was doing something. I thought I was fixing the timing of my glute flexing.
Right. It's my anecdote can say nothing about the validity of the
absolutely.
reasoning. Yeah.
Yeah. And what's odd, it's a bit ironic, is that explanation of the glute firing gave you permission to do the loading.
Right.
And unfortunately, maybe without that biomechanical explanation, you might not have done it. That's sometimes the problem.
Yeah, I think it goes
gives you
back
permission to load.
Yeah, I think what, like, going back to what you're saying, sort of being a salesman, like just giving them a story that they can latch onto, and if that helps them get from A to B, which is doing some sort of loading, it's still helpful in a sense.
Yeah, that's another question I have for you. It's right. We tend to be on the side of, we want to give people a positive story to tell about their bodies, and some people have really negative stories that really, drive their avoidance behavior. But it's hard to tell who is susceptible to those kinds of suggestions and who is just kind of, those kind of ideas are harmless and they're going to actually pursue a loading program regardless of the nonsense you say. How do you get a sense of that? Is that just a clinical thing for you?
You're always guessing.
Yeah.
That's a tough one. When is that a harmful belief that someone has? I mean, I had someone last week tell me, and I'm talking to him today, is like, he's like, we're doing Skype sessions, and he said, I want you to talk me off of this biomechanical ledge. So he's acknowledged that it's a factor, which is kind of neat, but he has that residual, well, how do I know it's not my disc? I don't want it to be my disc. I believe you, but a part of me doesn't. So I always, like, my joke with my patients is like, you'll start getting better once you trust your body as much as I do. Right. And that's what I think exercise and activity does. It has a mechanical and peripheral effect, but there's that, like, oh, I can do this, confronting yourself with your own strengths, the idea. And Steffi, that's what you can do with all those orthopedic tests. They don't tell you jack shit about what tissue is damaged, but you can flip your orthopedic exam on its head. Instead of finding like the negative things, you just say, look, that's an amazing Mears test, or that's the best O'Brien's test I've ever seen.
I literally do that every
Isn't
time
that
now.
amazing, Kemp's. So you don't have to throw that knowledge out. You just spin it.
Yeah.
That's funny. That's awesome. What are some techniques that you use to reduce the sensitization when someone has kind of like a highly triggerable pain alarm?
Yeah. So my approach is honestly like just activity resumption of activities, like talking to them and giving them like a slow goal setting, like starting to do 2 minutes of walking multiple times a day, or just going out for coffee for 15 minutes with their friends. So that's my approach. What I don't do well, and I always make jokes in my courses, like I'm not a breathing guy. Like I don't know how to breathe. I'm like, you got 3 holes in your face, pick one. Like that's not my thing. But I always say you could see someone about breathing or yoga or whatever it happens to be. I'm not a breathing person. So I with my approach and philosophy, I could certainly develop my skills in other areas to calm shit down. My big way is education and then reactivation. But I know that you don't even have to do that. There's other ways that you could do it. Those are the 2 that I feel good with.
I felt like when I was reading your pain handbook, which by the way, I've read about 4 times, I honestly felt like it was written for me. But this is the worst part. And the reason why I keep rereading it is because as much as I feel like I understand it, I feel like I can't necessarily apply it to me, if that makes any sense. So I've been having back pain for about 3 years, and I don't want to turn this into a consultation, although I might. I've been having back pain for about 3 years. I don't know if you know about me, but I'm a competitive power lifter. A couple of years ago, I was able to deadlift 547 pounds and at a body weight of 120. And to be honest, since then, I haven't really been able to get anywhere near it. Well, I deadlifted 530, but that was about it. And just been having kind of that back pain that comes and goes. And, you know, it literally just everything you mentioned, the sensitization, just having that pain alarm that gets triggered out of nowhere, the pain that moves around, the representation. Sometimes I walk into the gym and literally the distance that the bar needs to travel feels farther away. Like I feel like it's longer, or I feel like I'm off balance, or I feel like just my movement is not the same at all. And even just imagining myself doing the movement is almost painful. And I feel like I can't coordinate myself well. So my movement has changed. The way that I deadlift has changed, and I just feel like I can't progress, can't get back to where I was, no matter how much I work on understanding pain and trying to calm shit down and build shit up.
Yeah, is it the pain that's getting in the way of your improvement with training?
Yeah.
Yeah. And is it only deadlifting that you feel it?
I feel it also in squat, but it's way less. Way less.
Yeah, what does that tell you then? That it's not the same?
Yeah. That
like
it
when you
may
squat,
be
like what
related.
about like other complementary exercises? Like single leg deadlift or
I mean, I feel
different
it, but
styles of
it's
deadlift?
yeah.
What's that?
I feel it, but I can do them.
Yeah, but it's not the same pain, right?
No.
Oh shit, I'm losing you.
No, it's not the same pain. You there?
Yeah.
No,
It seems like a weird game of almost you have to use your conscious brain to plan ahead to trick your subconscious mind into like accidentally doing the exercise. You're like, this isn't a deadlift, it's a 1-leg deadlift, and then you're like, oh, I'm doing it. You know, it's like it kind of seems like that's the game.
I don't know.
And are you fine when you're training like weight, like sub max efforts and that?
Sometimes.
Like what's your other training like?
Sometimes I'm fine. Sometimes I'm not fine. You know, sometimes I come into the gym and I do 160 kilo deadlift, and it's great. I'm able to train the next day, and sometimes I do 160 kilo deadlift and I'm incapacitated for a week.
Really?
Yeah, it's so volatile. And I did get an MRI a few months ago, about 6 months ago, and to my surprise, there was nothing there.
Interesting.
I had a small bulging disc at L3-4, and then I had sacralization. but who knows how long that's been there.
Yeah, and like your training in general, how is it? Like, are you training the same that you used to train?
No, because I haven't been able to.
No, like leading up to when did the low back pain start?
Like 3 years ago.
Okay, and that's you cut out. I didn't hear that. I thought that was 3 months ago.
No,
okay.
3 years.
So that's when you did your max, your PR.
2 years ago, I got my PR. Yeah.
Okay.
And you had back pain leading up to it. How close have you been
since then?
How close? About 15 pounds away.
Okay. And how different is your overall training program now compared to then? Like,
completely.
Like have you played around with different loading, like a different training program?
Yeah, completely different. Like, honestly, I used to feel like I was made out of steel, man. Like, I could squat 4 times a week, deadlift 3 times per week, bench 4 times per week. On top of that, do a bunch of conditioning, and I felt great. Now I can barely do 2 squat sessions and 1 deadlift session every 10 days. I seriously feel like I'm 67.
So sorry, we can talk later if you like. I'd be curious to do this if you want.
Sure.
Because with things like that, like, I would look at sneaking in more load somehow, and I would stay kind of in not a biomechanical world, but stay in the mechanical world of how do you get load to get you to adapt in there, but differently. Mm-hmm. You know, and it might be cutting the weight and training more frequently. It could be like deadlifting twice a day, but not like a submaximal, like somehow sneaking in different types of load, like try different loading parameters to think of like getting your nervous system and your spine and everything to adapt, like just playing around with stuff like that.
Yeah, that's something that I haven't tried.
Powerlifting is certainly not a strength of mine, but with runners, like, and I would use the same approach. Like, some people might run 4 times a week and they run 100 kilometers. But the other approach would be like, you need to run twice a day. That's how we're going to get your volume in 7 days a week, where we stay under threshold for a while. And then you build like, you have just a slow accumulation of load, like that's multiple times per week, but you're staying under your threshold for a while rather than, so you said you just deadlifted once every 10 days?
Yeah.
Yeah. That's hard on the back.
Yeah.
You know, I mean, that's probably too infrequent or something like that. So it's like it'd be playing with your loading scheme.
Yeah,
would be the idea there, and then doing the tough question of like, and you've probably already done this, but like just looking at other areas of general health, because you've ruled out the red flags, which is great.
Yeah,
right, or the sinister stuff, and then like how can you be healthier, which is a harder reflective thing, like sitting down and thinking, what do I have to change in my life to be healthy? Is there something that needs addressing?
Yeah.
Which you probably don't want to do here.
No. The crazy thing is that I have been getting so much stronger. Like, I added 30 kilos to my back squat over the last year only. But my deadlift just stayed the same. I really liked your suggestion though of increasing the frequency, but like staying way sub max instead of trying to do it once every blue moon and loading it heavier. Yeah. That's something I'm gonna try for sure.
Yeah, and I would like, and then give yourself a bit of a break too, you know, like, and congratulate yourself on your strengths there. If you're squatting 30 pounds more, think of the load that goes through the spine when you're squatting it's pretty comparable to a deadlift. Yeah. It might even be more. I haven't read the research in a while. I don't know if anyone's really compared it. Like Escamilla, I think, compared it in 2001 or something. It's not. Is that right? Or 2003?
I don't know.
I don't know what paper you're referring to, but
Rafael Escamilla. Yeah. I'll pull it. I'll send it to you. Where I would think that squatting isn't really that much easier in terms of the external moment on the spine. So you can do it.
Especially for you because of how good your leverage is for deadlift.
Exactly, yeah.
You know, it's probably individualized. Right, there's a range. But yeah. That's super interesting. Also, the frequency has its own psychosocial component too, because it feels like you're still in it, as opposed to taking like, oh, I haven't deadlifted in 2 weeks. Like, hopefully it's there today. Yeah, hopefully today's a good day, right? If you have a bad day, you can get over it and get on to the next one because you still have more to do.
That's it.
more to learn.
And you're also not going to be failing reps if you do it that way. Whereas if you're trying to go heavy every 10 days.
And you can see the progression a little clearer because it's more proximal.
Yeah.
Unstable connection.
Did we lose you, Greg?
Yeah.
Okay.
I can't hear you. Sorry.
But we're okay now?
Yep.
Okay. What were you saying, Ian?
Oh, just I like the high frequency approach to sub pain threshold training, just for the kind of the encouragement it provides people that they are training and continuing to move and participating in the thing that they enjoy to do. And also it allows you to put bad days behind you faster and continue to improve in ways that you don't really get to see as easily if you're lowering the frequency but trying to keep the intensity of the session higher.
Yeah, I mean, you guys know this from working with people, but it's really hard to train yourself. Is that you probably have athletes that respond differently to different type of loading programs and training programs. Yeah. So like, and your body and nervous system and your whole ecosystem will have changed from 3 years ago.
Yeah.
Right. And so,
Absolutely.
you know, it's always trial and error, figuring out what's the right thing for you right now.
Absolutely. Yeah. The hardest,
but it's really hard to do it on your own.
Yeah.
It is hard. And the most difficult part about being a competitive powerlifter, and for me, it's kind of, it's an important part of my business to compete and kind of walk the walk. So if I'm competing multiple times per year, taking time off or taking it slowly hasn't been an option over the last 3 years. And I feel like that has dug me even deeper into the issue.
Yeah, because you've had to dive back into training, whether you were recovered or not.
Exactly.
You were like, oh, well, my back still kind of hurts, but I guess I'll just
take 600 milligrams of ibuprofen and suck it up, you know?
Yeah. And so it sounds like a good case where often people need to be encouraged to do something into discomfort because they're avoidant, but I don't think that you were avoidant. You know, you would be classified as not to classify you, but to tell you what you are. But it sounds like you're more of a persistent or an endurance coper.
I think she's textbook.
Someone might want to encourage you to back off and give you permission to back off a bit. It might be a touch helpful.
Yeah, I mean, you'd be in the gym 5 hours a day if we didn't drag you out.
Yeah.
Yeah.
Do you teach any of this in school? Or do you
a formal program?
No, so like as a like guest speaker?
No.
Man, you should. We desperately need this in school.
But then if they had him come in, they'd have to undo the entire curriculum.
That's what I said.
They would have to change the questions in the boards exam.
Yeah.
They actually should do that. Probably.
No, I haven't been to any physio programs, but the chiro training here was pretty good. They acknowledged a lot of this stuff when I was there. They weren't teaching motion palpation and saying people's SI joints are out of place. So I think things are changing.
Yeah, things are changing, but it's in a weird transition, I feel like, too. Because sometimes it's a framework without a philosophy, right?
Yeah.
And then you're like, does even this framework make sense? You know, is there a better one? You know, that explains, you know, what we're seeing in the data. But
yeah, that's tough.
Yeah.
Good luck.
Yeah, well, I think, you know, you're in the same boat. It's hard to be one person to change an entire, you know, kind of organization of interests that are pretty deeply kind of ingrained in the profession.
It always starts with one, though.
Yeah, we need to build a movement with some momentum.
He is. I don't know if you realize, but you have a legit following.
Oh, that's cool. No, I don't.
Yeah, a cult following of Lehmanites.
Oh,
the Lehmanites. No, yeah, man. People.
And a movement optimist. That's better.
Yes. No, people are loving it. Do you feel like you've kind of? I feel like he's come out of nowhere. Where have you been for these 15 years, man?
I've been saying this stuff for almost like at least 15 years, and some of the things for 20 years. It's just I was a popular researcher 20 years ago, and then I disappeared into clinical practice for 10 years. And then I popped up again the past 8 years. I had to treat more patients first.
Do you have any plans of, marketing your approach or bringing this everything more to life or onto the life?
I mean, so I've been teaching my course for 4 or 5 years now, which is 2 to 3 weekends a month. So I'm pretty booked with that stuff. But I certainly don't do a lot of promotion anywhere. I probably should or something like that.
Have you been invited to any professional association conferences or anything like that?
I'll get a few keynotes at places, which is fun. I was just at like the World. Was it the World? It was the sport physiotherapy, maybe the Canadian Sport Physiotherapy Conference a few months ago in Vancouver. I'll get 1 or 2 of those a year somewhere in the world.
Are you received well at those talks? People might select into them, but
I mean, it depends what I talk about. I went to a Cairo conference once and I had like 2 minutes, and it was like 6 years ago, and the theme was everything you think you know is wrong.
I love it.
It's fun.
Yeah, Greg, I think the only thing that you're missing is some swagger. And I think I know who can help you.
Yeah. I don't know.
So what's the future look like for you? What kind of research questions are you looking to answer, if any?
I have some relationships with some spine biomechanists here in Toronto, and we're going to do some research. It's a bit on hold because they're super busy, but we're going to actually try to document, better ways of measuring lumbar spine flexion. Take a look at, and one of these guys is Tyson Beach, who's a great researcher, strength coach. We're going to look at people lifting heavy weights and what their spine does during those activities. How responsive the spine is to, like, how easy it is to change your spinal flexion position, because that's the thrust. Like we as people assume spinal flexion is inherently wrong, and if you can't do anything about it, then what's the point in worrying about it?
Yeah,
right. Like when you guys train, I would say if you change your spine position, it's your thoracic spine that's changing and not your lower lumbar spine. I think when you see that question mark, it's the thoracic spine. Yeah. I don't think the lumbar, that's my belief. I don't think the lumbar is really changing that much.
Yeah, I think it's super interesting. Like when you get a clinical education, a lot of people tend to believe that the biomechanics is like settled science, that, we know everything there is to know about it because they're just not in the biomechanics world. And something that you've brought out, I think, or transition into some people's kind of clinical knowledge base is that, man, there are a lot of questions. So where are the limits of our world when we talk about biomechanics?
So if you look at, I always say it's the biomechanics that challenges the biomechanics.
Yeah, which I love that.
What happens is certain researchers become really popular, and that gets taken as dogma, and we ignore these other great researchers. Like the stoop versus squat debate, the squat debate, like spine flexion versus neutral, has been going on for 30 years. And if you look at a biomechanist named Patricia Dolan, 30 years ago, she was advocating for a flex spine is safer as long as it's not past 85% of max. She always argued against neutral, but no one ever hears about her.
Yeah,
she won awards. She's fantastic.
Yeah, that's interesting. I actually have that in my notes.
There was one other piece that I wanted to touch on. You go ahead while I think of it.
Well, I just had a question for the closing notes. Related to some actionable steps for people when they encounter an injury, kind of what would be their step-by-step approach, and how can they use pain as a guide instead of something that makes the process worse?
Oh, good one. I mean, if there's trauma, you should get things checked out, or if things just, like, you can trust your body too. If things feel really weird and you're really worried, get checked out by a professional. Like, rule out those red flags and the sinister stuff. We'll get someone to rule them out. Mm-hmm. And then after that, once you've done that, know that, surprisingly, pain is not the best indication of how much damage there is. And so moving is still good. But at the same time, like, we've taken this advice, like, keep being active, because we don't want people just lying on the couch. But that doesn't mean keep hammering your spine. It means you're allowed to take it easy for a few weeks. Like, give yourself a break. You're not, for athletes who push too hard, giving them permission to, like, explain you're not going to lose your gains. You can cut your volume and intensity to 50%. You can do other things that's going to maintain. Take this as an opportunity, as a deload for a few weeks. Like, that's what I would recommend, and then slowly build back up. If things aren't improving in a few weeks, then again get checked out again and figure out another plan there. But know that there's lots of ways to help with pain, and the vast majority of times that we have low back pain, it's not serious and it's normal, unavoidable, and usually goes away on its own with some modifications. So I guess it's not on its own.
All dangerous ideas.
What's that?
All those ideas are dangerous to the status quo.
No, that's conventional wisdom.
I'm kidding.
And then get your neck manipulated, and that'll set everything up fine.
There we go.
3 times a week, 6 weeks.
Feels good though.
It must be.
It's fun to do too.
Yeah, it is. The
I love
moves are
cracking
pretty
necks.
fun.
I don't do it anymore.
Yeah.
Wish I could just light up my whole family.
You had another question or no?
It escaped me.
Awesome.
We'll have to hit him up later.
Okay, Greg, thank you so much for your time. We really appreciate you coming on this show, and we hope to have you again as a guest.
Yeah, for sure. I threw the video back on so I can see you guys.
Perfect. You're in Toronto, right?
Yeah.
Yep. Yeah. That's where I grew up for.
Oh, really?
Yeah, for 23 years. So if you ever need
Where?
access, I started off in High Park.
And
then,
my wife's from there.
Oh, really? And then
Yeah.
I spent the majority of my childhood down in Mississauga, South End, like Mississauga Road in the QW area. And I've just been in Miami the last 4 years. So if you ever need powerlifters for a study or anything,
Yeah,
let
I was
us
going to
know.
say, for that study you want to do, I know a bunch of strong people.
Yeah, we know
In Toronto.
In Toronto, yeah.
Yeah, for sure.
And I'll be in it if my back is,
We got to do the
stronger.
boring stuff first to make sure our the methods, like the equipment's good, and then we can start getting it. I don't know how long this will take. These guys are really busy, and they're the brains behind it. So,
Well, whenever you're
it's
ready,
up to them.
we'll help you gather participants.
Yeah, that'd be awesome.
And yeah, hey, I would love to schedule a consultation with you.
Yeah, shoot me an email. We can
Possible.
talk through email. Shoot me an email just telling me, like, the whole story and
The whole
how you're
deal.
feeling and what you think's going on.
Okay.
And
Perfect.
we can
Yeah.
get started with that.
Because I'm not ready to retire. I have
No,
some
no,
goals.
I don't think you have to. If your squats improve, that should tell you something.
Yeah.
That
Cool.
tells you your spine can figure it out. You just got to figure it out.
Mm-hmm.
Figure it
That's
out.
it. There's a path. You just don't know where it is right now.
Mm.
Right?
Yeah.
Yeah.
But if your spine can handle that load of the squat, so there's something there.
Sounds
Awesome.
good. Awesome.
Thanks so much, Greg.
Thank you, Greg.
That was great.
Appreciate it.
Okay, thank you guys.
Have a good day.
Okay, take care. Work on your back flip.